All right, welcome to the Explainer. Today, we're doing a deep dive into atrial septal defects. We're going to cover everything from that classic physical exam finding all the way to the big management decisions, all the stuff you'll actually see and need to know on your rotations. Okay, let's kick things off with a classic board-style question, one you're almost guaranteed to come across. What congenital heart defect classically causes a fixed split S2 on physical exam? When you hear that phrase, what's the first thing that should pop into your head? Think about it. We'll circle back in just a second. And if you were thinking atrial septal defect, or ASD, you nailed it. That fixed split S2 is the absolute hallmark finding. So let's break down the anatomy and figure out why that classic finding happens in the first place. So at its most basic level, an ASD is literally just a hole in the wall, the septum, between the heart's two upper chambers, the atria. Now, because the pressure on the left side of the heart is way higher than the right, blood takes the path of least resistance. That means oxygenated blood flows backwards from the left atrium to the right, and that is the core of the problem. All that extra blood volume puts a ton of strain on the right side of the heart, causing it to stretch out or dilate over time. Okay, but here's where it gets interesting. Not all ASDs are created equal. Where that hole is located is super important for how we diagnose and treat it. And you can see from this chart, the vast majority, we're talking about 75% of them, are what we call ostium secundum defects. They're located right in the middle of that atrial septum. So let's zoom in on the big three. The ostium secundum is usually an isolated issue, but when you see an ostium primum defect, which is lower down, your brain should immediately jump to thinking about the mitral valve. They're often found together. And this is a big one. If you've got a sinus venosus defect way up high, you absolutely have to look for anomalous pulmonary veins. Missing that is a huge deal and totally changes your management plan. All right, we've got the what. Now for the how. How does this actually show up in a patient? What are you going to see in the clinic? What should you be looking for? The crazy thing is, a lot of people with an ASD have zero symptoms for years, even decades. But that constant volume overload on the right heart eventually catches up. Patients start feeling tired, getting winded with exercise, and in older adults, that stretched out right atrium becomes a perfect setup for arrhythmias, especially AFib. Now for the fun part, the physical exam. Everything you find points directly back to that right heart volume overload. And there are three key signs that when you put them together, practically scream ASD. Okay, finding number one. Put your hand on the patient's chest, just to the left of the sternum. You might feel this thump, a right ventricular heave, or a parasternal impulse. That's literally the enlarged, overworked right ventricles slamming against the chest wall with every single beat. All right, and here's the big one, the absolute classic board question favorite finding, a wide, fixed split of the S2. Remember, S2 normally splits a little when you breathe in, but here, the right ventricle is always overloaded with blood, so that pulmonary valve is always closing late, no matter if the patient is breathing in or out. That's why we call it fixed. And finally, finding number three. You're going to hear a systolic ejection murmur, usually best right over the pulmonary valve area. Now, this is a super important point. The murmur is not from blood crossing the ASD. The pressure difference there is too low to make a sound. No, this murmur is from the sheer volume of blood, the normal amount plus the shunted blood, all getting squeezed through a normal-sized pulmonary valve. It's a flow murmur, pure and simple. Okay, so your history and physical exam are pointing you straight towards an ASD. You're pretty sure you know what's going on. But how do you prove it? Let's talk about the imaging toolkit. Your first line, go-to test is going to be the transthoracic echo, the TTE. It's great for spotting most defects and seeing that right heart enlargement. But what if you can't get a good look? Or you're hunting for one of those high-up sinus venosus defects? That's when you'll level up to a transesophageal echo, a TEE, or maybe even a cardiac MRI for the best pictures. And one more thing, if you're worried about high pressures in the lungs, pulmonary hypertension, then you've got to go for the gold standard, a cardiac cath. That's the only way to get true pressures and measure the shunt size precisely. All right, so the diagnosis is confirmed. Now comes the big question, the one that really matters for the patient. Do we close this thing or do we leave it alone?
And this is really key. You don't automatically close every ASD you find. It's not a one-size-fits-all situation. The whole decision really hinges on one question. Is this shunt actually causing a problem? Is it hemodynamically significant?
So it basically boils down to this. We're going to recommend closure if you see clear evidence on the echo that the right heart is getting bigger, or if the patient is actually having symptoms, like getting short of breath. But if you've got a patient who feels totally fine, the ASD is small, and their right heart looks perfectly normal on imaging, then we can just watch and wait. We'll monitor them, but no need to intervene just yet. Okay, so we've decided to close it. How do we do it? Well, the how is almost completely dictated by the anatomy of the defect. For most of those common mid-septum secundum ASDs, the good news is we can usually fix it with a minimally invasive procedure. We go in through a catheter and deploy a device that plugs the hole. It's pretty slick. But for those other types, the primum or sinus venosus defects, or for secundum defects that are just way too big, we've got to call the surgeons. That requires open heart surgery to patch the hole directly. All right, let's fast forward. The procedure is done, the hole is closed. What happens next? What does life look like for these patients long term? The follow-up care is actually pretty standard. Basically, you'll see them for a checkup and get an echo within that first year. You're just making sure the device is in the right place and there's no leak. After that initial check, it's just periodic follow-up, tailored to how the patient is doing. Now, here's a specific detail you don't want to forget. For the first 6 months after closure, doesn't matter if it was device or surgery, these patients need antibiotics before certain procedures. Why? Because it takes about 6 months for the body's own tissue to grow over the device or patch. Once that happens, the risk of infection or endocarditis goes way down. But, and this is a really important but for patient counseling, closing the hole does not turn back the clock completely. The key takeaway here is that years and years of that extra volume stretching the atria can leave permanent scarring. And that scar tissue is a perfect setup for arrhythmias. So the risk of AFib doesn't just disappear. In fact, the older the patient is when they get the ASD closed, the higher their lifelong risk of AFib. And that really brings us to our final and maybe most important point. Think of it like this. The atrial tissue has been remodeled by years of being overstretched. It's fundamentally changed. Plugging the holes stops the shunt, which is great, but it can't undo all of that structural damage. The setup for AFib is still there. And that is exactly why catching these things early and intervening at the right time is so crucial. It's not just about stopping the shunt. It's about preventing those irreversible changes to give our patients the best possible long-term outcome.